So we're just here to speak about treating the foot and ankle, just utilizing our general concepts, right? So broad contact, contact as control, broad contact for multi-point discrimination, multi-sensory integration. All of these concepts we're going to utilize. The basic concept here that kind of ties everything together is the idea of broad contact. What I want everybody to be aware of is when you're working with the foot and ankle, especially with the foot, so when you get into the tarsals and the calcaneus and the talus and the phalanges and all of those things, it's very easy to place a lot of force in it. Now the foot's pretty robust, so you don't have to worry too much, but it's very easy to put quite a bit of force in here, especially because you're going to be quite close to it and you'll use a lot of pressure, so you want to be careful with that. When we're talking about the ankle, again, the ankle's quite robust. What I would suggest as far as testing the ankle is to test it with a fairly loose grip, right? So to just test the ankle, dorsiflexion, plantarflexion, inversion, eversion, just generally, right? We can have the patient actively do that, but we don't absolutely have to, but we can do that. The reason I would say do it with a loose grip is you'll get an idea of resistance and barrier and bind easier than if you use something like you would to treat it. Now you see how I approximate to the foot. I utilize my thorax, right? So dorsiflexion becomes quite easy. Here I can stay in nice and tight, keep my arm in, wrap up, right? So broad contact, right, as far as the ankle is concerned. Now, if I go very slow, I can get an idea of what's going on. However, it's very easy for testing purposes for me to really be overbearing because I can use quite a bit of body weight there. So if I was to suggest something when you're testing what the ankle is doing, to, again, have a loose grip. When you actually want to treat through the ankle, okay, as we showed already, you come in nice and tight. Now, if for whatever reason there's an issue and you feel that there will be a problem having the bottom of the patient's foot directly in contact with your body, then what you could do is use a towel or a pillow as a barrier. Right? Now, it's not a necessity, but it can be useful in some circumstances. But again, if we're working on the ankle, I'm going to cup around the calcaneus, I'm going to use my body, and right here what we see is, again, a lot of contact for a lot of control. So I can work through all ranges. Okay? Dorsiflexion, plantarflexion, inversion, eversion. I can mix those up as is needed. Now, with this hold as well, should I need it, especially because I wrap around, I can create traction at the ankle, right? I can create some separation, some gapping. Although it will be minor, it won't be very large, I can do it. If I wanted to use a patient passive mixed with a patient active approach, if I wanted to create specifically traction, again, I'm nice and tight. What I have the patient do is I want you to hike your right hip towards your right ear, have them pull up and then let go. And what we get with the concept of relational motion is I'm pulling down on the foot, generally speaking, so I'm pulling the talus away from the tibia and the fibula, and then as the patient pulls his leg upwards, we're getting relational gapping. So I'm holding this still, he pulls up, or I can just simply pull down. The net result, or the net motion is similar, but the amount of force applied is much greater when the patient pulls their own ankle up, or sorry, their own leg up. So, again, working with the ankle, you get nice and tight, broad contact, you cup the calcaneus. Now we start to move into the foot itself. So you can look at how the calcaneus interacts with the talus and the cuboid. You're going to cup, as far as looking at the calcaneus is concerned, you cup the calcaneus, make sure the calcaneus relatively stays still, and then you can move the foot in relation to it. Now the talus won't move heavily in relation to the calcaneus, but because of the way the rest of the tarsals will move, the foot, you're going to get an impression of greater movement with respect to the cuboid, right? Now, what I can do, if you watch, I can kind of push across the foot or across the calcaneus with the cuboid and the talus, right? So I can push and I can pull, right? There's not going to be, again, a ton of motion, but sometimes you'd be surprised at the type of relief that the patient will present. Now, that might be a relational thing. It might be a subjective feeling that relates to what I've done. It may not necessarily be the movement that we've created, but often the patient will report positive subjective feelings. But what we can do, again, with that concept of relational motion, I can do this across the foot, or I can hold the foot still and move the calcaneus in relation to the foot. Again, expect small amounts of motion, but I can come in nice and tight, and I can use that same hold. Now, getting down into the tarsals themselves and moving tarsals, the metatarsals and the phalanges, what we get, this isn't going to show up perfectly, but if I hold high on the foot, if I hold over the talus, then I can move everything below the talus. I hold the talus still, relatively speaking, and I can move everything below it. This isn't the perfect hold. More likely than not, I would actually be over here, holding, and I would move, right? Now, when I move, depending on the size of the patient's foot, or when I hold, my fingers can come over, right, but I can't get all the way around, right? So I can't control all the metatarsals, all the phalanges, all the tarsals. I can't control them all. But if I actually give up a little bit, come over here and bring my thumb under, I can get a little bit more control. So I bring my thumb closer to the lateral side of the foot, I get a little bit more control. So I can move the foot as a group, or all the bones of the foot, distal to the talus as a group in relation to the talus. I can move my fixed point down to the next row of tarsals, metatarsals, and so on, and I can move these things in relation to one another. I can do that in a gross fashion, or I can do it in an individuated fashion. It doesn't work as well with the tarsals, but once you get into the metatarsals and the phalanges, you can essentially move them in relation to one another. So what I do, grab metatarsals here, grab phalanges here, and I can move one in relation to the other, and then I can hold still here, and I can move there, right? So we get an idea of how they're functioning in relation to one another. And then with the test, the treatment just simply becomes an exaggeration of the test, as is often the case. When you find bind or barrier, you can simply engage it and hold. You can get patient-active methodologies going at the same time, but the idea is that once you find the bind, the treatment is simply a slight exaggeration of that, right? And then we can start to articulate these bones in relation to one another. Again, you'll see my hold looks quite a bit like this, although it's on the foot, you can't see it perfectly. I wrap around to the top and the bottom of the bones. I'm attempting to move in relation to one another, right? But that broad contact still applies. Although the hold looks like this, it's still broad contact. I'm broadly on the bones that I'm attempting to move them in relation to one another. So again, that concept of broad contact and relational motion comes into play quite a bit here. But the basic ideas being that good hold, move them in relation to one another, test, and treat as is needed, but the contact being very important. And then going back just to the beginning, as far as testing the ankle, maybe do it with a loose hold so that you don't overbear. It's very easy to overbear. Obviously, if you were going to be looking at the foot, you'd probably also be looking at the leg and everything above it to make sure that there wasn't any muscular tension or other issues that might be abnormally loading the foot. But if all of those things are okay when you actually get into the foot, the two most common holds, or the two most important holds, right, you just wrap it up, work there, and then here, nice, essentially a yoke hold, and you can start to move grossly right there.